evening. On behalf of Center Pharmaceuticals, I would like to welcome the eminent speakers and the moderator for this webinar. I would also like to welcome the audience for this webinar on interventional nephrology. At the outset, I would like to thank Center Pharmaceuticals for sponsoring this webinar. Though the moderators and the speaker require no special introduction, they are already known faces in the field of nephrology. I would still have the privilege to introduce our first moderator for this webinar, Lieutenant General Dr. P.P. Verma. He is a senior nephrologist from New Delhi. He is the director and HOD of nephrology at Venkateshwar Hospital in Dwarka, New Delhi. He is a nephrologist with more than 40 years of experience, and he has in the past worked as an honorary surgeon of President of India. So welcome, sir.
Thank you very much.
He is going to moderate a session on tunneled catheter techniques and troubleshooting. The speaker for this topic is going to be Dr. K. Sampath Kumar. He is the head and the consultant nephrologist at Meenakshi Missions Hospital and Research Center at Madurai, Tamil Nadu. So welcome, sir.
Thank you.
Our second moderator is Dr. Georgie Abraham. He is the HOD nephrology of Madras Medical Missions Hospital in Chennai. He is also the founder trustee of Tamil Nadu Kidney Research Foundation, the Tanker Foundation, which is a charitable trust to help patients with kidney disease. So welcome, sir. He is going to moderate the session on PD catheter insertion techniques and troubleshooting, for which the speaker is Dr. J. Balasubramaniam. He is a consultant nephrologist at Kidney Care Center, Tirunelveli in Tamil Nadu. So welcome, sir. I would request our audience to key in your questions which you have in the question box, which is very near to the window of video. Now, I would request our first moderator, Dr. P.P. Verma, sir, to take over the proceedings. So over to you, sir.
Thank you very much, Center Pharmaceutical, for giving us opportunity to be here. You are all aware that it is going to be almost 6 horrible months when the coronavirus first appeared on the world scene. And gradually it has engulfed the whole of the world. If you look at the figures today, almost 7 million people in the world are infected, and there have been 4 lakh deaths. In India, if you see the official figures, there is 2.3 lakh cases and close to 7 lakh deaths. Though we know the disease affects primarily the lung, but if you look at the kidney, I can just give you just 1 or 2 slides to tell you. If you look at the acute kidney injury, initial data did suggest that kidney is not involved, and the initial Chinese data showed that possibly less than 5% of the patients have acute kidney injury, which is true even today. But the patients who require ICU care, they have got pretty high incidence of AKI, almost 25 to 30%, which is the data from Italy and the data from US. And once these patients develop AKI, the mortality is almost 25 to 50%. Now, there was so much of AKI occurring in US that people did not know what sort of modality to use. The CRRT machines were exhausted in all, whether it was Italy or it was Spain or it is US, and gradually people came down to peritoneal dialysis as a last resort because there were no resource to do CRRT. If you look at the chronic kidney disease, we know that CKD population is a very vulnerable group. And initial data from China suggested that the disease in CKD population is very mild. They found that out of one of the centers, 230 dialysis population, 16% developed COVID, but fortunately they found that there were 7 deaths but not related to COVID. Now, but when you look at the Brescia data, you find clearly that patients who get hospitalized, CKD patients, for COVID, a large percentage of them, 29% of them, are going to die. They found that there were 94 patients who had COVID positivity among the CKD population, and patients who were in group 1, that is patients who did not require hospitalization, 8% died, but patients who required hospitalization, 42% died. And likewise, this is similar is the data which appeared from US recently, that out of 57 patients who were on hemodialysis, 31% of the patient died. Now, this is a huge figure. And the problem comes, what should be the vascular excess in our population? How should we dialyze these people? Initially, the advisory came that all the surgeries should be stopped. All the interventions should be stopped, and we should not do fresh intervention. However, gradually, the times are changing now. For last 6 months, everything has to change. What should be our strategy now? I think we have got an iconic figure in interventional nephrology, Professor Sampath Kumar, a dear friend of mine, and who has been leading the interventional group always. Now, he is going to talk today about the tunnel catheter. Mind you, if you are talking about ICU or other things, we are not talking of tunnel catheter as such. We are talking of temporary catheters today. We are talking of femoral catheter or IJ catheter. But if we have to look at our permanent population who is requiring dialysis, whether we do fistula, whether we do tunnel catheter, we go to Dr. Sampath Kumar for his discourse on this. Dr. Sampath Kumar.
Thank you, sir. Thank you, sir, for your kind words. So we'll have an overview of how tunnel catheters could be useful during this COVID era. As doctors, we had 3 phases of mindset during the COVID era. The first set happened when we realized that India is no longer immune to this invasion. So it was a total shutdown of most of the interventional activities. And then as days went by, we realized that this type of hibernation is leading us nowhere. So we'll have to take a graded resumption of the interventions in the field of nephrology, because we realized that in contrast to the other fields, there was no let-up of our dialysis schedules and no let-up of the patients who are wheeled into the dialysis room. In fact, COVID has made them more resolute that they will have their regular dialysis. When during the pre-COVID era, when we were cajoling them to have regular dialysis and they were looking the other way, now it was the turn of the patients insisting on regular dialysis. And this is what we are dealing with now. And will we ever go into the pre-COVID state? I think it is a visual thinking that we have to learn to live with this corona, and we need to change our perspective on how to manage our hemodialysis patients and the access. So the variety of the scope for interventional nephrology is enormous. Starting from renal ultrasound to tunneled catheter placements to the AV fistula troubleshooting and PD catheter placement and renal angiograms. So the access for the maintenance hemodialysis, it is a common experience that less than 5% of our patients start with a functioning AV fistula when we put them on the maintenance hemodialysis. And acute, the non-tunneled catheters are most commonly inserted at the start of the MSD. And the AV fistula scheduling has been really hit hard by the COVID due to the reluctant surgical colleagues who think that AV fistula is not an emergency operation, it's an elective procedure. So we are left to have the problems of the access, intermediate level access. For example, we need to tide over this crisis of 3 to 6 months or even 1 year with an access which is not dependent on the surgical expertise. And high rates of infections and dysfunction of the acute catheter make us to search for alternatives. And the advantages of the tunneled catheter should not be lost on us at this stage. The learning curve for the nephrologists is going to be very short, because I have been conducting the workshops for more than 10 years, and many of the junior nephrology colleagues who are attending the workshops immediately go back, gain confidence just on seeing somebody operating or somebody inserting the catheter, and they start putting in. So I get the news that they have started full in many catheters have been inserted in immediately after the workshops are over. The tunnel catheters have immediate, you can use them immediately with excellent blood flows of more than 250 to 300 ml per minute. The life of the tunnel catheters are, I will say, very adequate for our dialysis patients during this period. In fact, in our unit, the 3-month life is 85% of them are functioning, 68% at 6 months, and more than 1/3 of them are still functional at 1 year. And the infection rates are also very much reduced with adequate prevention. So in our unit, we even without infections, we see to it that these patients have a catheter lock solution made of antibiotic. This was the tunnel catheter insertion experience, which was published way back in 2011. And it is important to choose a proper catheter for the proper placement. And among all the aspects of a catheter, it is the tip of the catheter which may be very, very crucial, which determines the recirculation, the thrombosis risk, and the infection risk. And you have basically 3 tip sizes, types: the split, the step, and the symmetric tip. Single body double D step tip design, which we have been using for many years now. The split tip catheter has come up, and it is also very useful because the ash split tip with twin tips, which seem to have lesser dysfunction, especially for the arterial wing. And you have now the palindrome or the double D laser cut catheters, which reduce the recirculation and also provide excellent flows with reduction in the thrombosis. So as far as the personal preference is concerned, I would like to use the step tip split or the symmetric tip for the right IJV. Whereas for the left IJV, I am not very comfortable with the split tip, as Dr. Bala also will concur with me, that either it will be a step tip or a symmetric tip, which I am comfortable because of the convoluted route that the left IJV takes before joining the superior vena cava. There are possibilities that when you are inserting a split tip, it may not insert well, and you may have higher complication rates. So one of the most important tips that I would like to give is that they make the IJV entry point as close to the clavicle as possible, because this you will most of the time you may do it under ultrasound guidance. But sometimes if you are very confident that the internal jugular vein is very big and it is very prominent, you need to just make a skin point of just a mark, and then you can go ahead. Make the entry point as close to the clavicle as possible to prevent the kink. And the other point that I would like to make is again that once you are inserting the guide wire, you can see that the guide wire is slowly being put into the inferior vena cava. So you should try to negotiate the guide wire so that it goes into the inferior vena cava. So everything will be in a straight line. So this is the diaphragm, and you need to go into the inferior vena cava for when you are doing the skin tunneling. So this is once you put in the guide wire, so with a graded skin you need to, the tunnel has to become big, and you should see to it under continuous fluoroscopic guidance that there is no kink of the guide wire. If the guide wire kinks, then you are in for trouble. So after that, you are having this peel away sheath. Already you have this split catheter from the exit site. You have tunneled it and then you have brought it out at the neck. So as you are inserting the peel away sheath, it is ideal that you make the patient into a Trendelenburg position, and then also ask him to have a Valsalva maneuver. So these small things will reduce your anxiety of development of the air embolism. So as soon as you enter, and then you should start inserting the catheter, and you can start the split. You can start splitting the outer sheath. You should see to it that you slightly remove the catheter, you remove the external sheath, and then you split it. All the time looking at the fluoro, and see to it that you are at the mid right atrium. So we have made a very small incision. So it is now in the right atrium, and you can give a small tug here to see that there is no kink at the top. So the top is also very nicely, there is no kink here, and you see that there is a good flow of blood. So I am sure all of you are very familiar with this. I just wanted to set the scene so that we can have discussion at a later stage. So as far as the, if you want to exchange a catheter which is blocked or infected, it is very important that when you are having an infected catheter due to a tunnel infection or a cuff erosion, catheter biofilm will be a major issue. And if it is a blocked and thrombosed catheter, or if there is a fibrin sheath which is producing a blockage, then you need to remove the fibrin sheath and also do a balloon angioplasty of the fibrin sheath before you put in a catheter. But if it is only a thrombosed tunneled catheter, then you can remove it and then exchange it. But you should not exchange a catheter which is infected with, when the patient is in severe sepsis and with hypotension. So it is better that these catheters are removed, and at a later stage you can have a fresh catheter inserted. It is when you are going to exchange a catheter, right side is preferable, and the guide wire that you are going to choose is going to be slightly different, and you need to have double gloves so that you remove the glove as you remove the first infected tunnel catheter, and then you insert the new catheter with a new glove. The wire which we are going to choose should have slightly more steerability and also some degree of torque, and it should be opaque, and the amount of force which is needed to advance the wire should also be not very great. So this was the Medtronic PTFE guide wire which we have used in this case, and I am now trying to remove and exchange this catheter. This is the tunnel catheter which I am exchanging. So again, when you want to remove a tunnel catheter, you have to see that you have a good dissection before you pull the catheter. And I used to think that if you have an argument with your wife and then you start doing this procedure, this is not the procedure to be done when you had an argument with your wife, because if you pull with all your might, suddenly the proximal part of the catheter may give way, and we have had complications like that, and the proximal part of the can slip in, and we may have to be removed. It has to be removed by a snare. So you have to be careful and dissect it all around, especially at the posterior aspect. The cuff has to be properly dissected, and also you may have to use scissors to see that the surrounding tissue is totally free. And then you remove it after putting in a guide wire. This guide, as you are removing, you can also put in a dye and see whether there is any stenosis or fibrin sheath. So you are putting in the other guide wire. And the new catheter has been put in, so it is functioning well. So as far as this is another problem that I faced in a patient who has got a diabetic end-stage renal disease, who had a peripheral vascular disease with above knee amputation. She was admitted with fluid overload, and her creatinine, she had to be dialyzed. And the right IJV catheter, which was inserted without difficulty, but you can see that the IJV catheter has coursed not into the right atrium, but it has coursed onto the left side. So we had a issue whether it was coursing into the posterior mediastinum, into the azygos vein. But to our consternation, we realized that a CT venogram was performed, and we showed that it showed that there was a persistent left superior vena cava. So this was the dye study which showed that the dye was not going into the superior vena cava, it was coursing into the left superior vena cava, and it was draining into the coronary sinus. This is the transverse coronary sinus that you are seeing here. So we had to, we did not have many options in this patient, and we chose that we'll do a left-sided tunneled CVC, even though that was the only conduit that we had. So it is it is the most common thoracic venous anomaly. 0.5% of the general population may have it. It commonly drains via the coronary sinus into the right atrium, and it drains into the left atrium in 5 to 10%. And there are other cardiac anomalies in 40 cases. So this patient, so we put the guide wire the internal coursing directly into the coronary sinus. It is coursing straight down. So this is because of the persistent left superior vena cava. And we are able to tunnel the so you can see that the catheter is put in place on the left through the left persistent superior vena cava, and this catheter, there is a small kink there, and this kink is relieved with a tug. Yes. So on the left side, we have the problems of insertion of catheter on the left side are slightly more. We have to ideally choose a step tip or a symmetric tip catheter, and we should also see to it that the catheter, the needle insertion sites are sufficiently lower. And this was one of the queries which came from my dear friend Dr. Wali from Hyderabad, when he had a small kink at the top of the perm cath that he had inserted. And what we did was give a small tug, and the catheter, the upper part of the kink disappeared. So these are all very small tricks which will go a long way in improving our success rates of catheter insertion. And I was particularly impressed by the experience of the KEM hospital paper, which I was a chairperson when during the last Indian Society Nephrology conference, that they had used 70% ethanol for infected catheters. And after the conference, I have started using it, and I found that it was very useful. So what you can do is, you have this is 100% ethanol is available in the laboratory, and you will have to dilute it to make it 70%. And this is very useful for eradication of the biofilm, especially when tunnel catheter patient has recurrent rigors. So these patients, you can fill the venous and the arterial ports separately, and 4 to 6 hours later, you can remove the ethanol, and then we are able to have more than 80% salvage rates of the biofilm infected patients. So I think this is again very useful method. I don't think I have seen a publication of this, but it is worked very well in my unit. So I think I'll stop here and then field the questions. Professor Verma, please.
Yeah, I think wonderful. As usual, Dr. Sampath, you have given the nonsense of how to put a catheter. So basically you said you prefer on the right side. You prefer it has to be done under fluoroscopy. You mentioned the bother about tip and top. Your tip is in the atrium, and the top the kink should not be there. And if the kink is there, you have told a little thud is there, and it should be as close to clavicle as possible. Going little off the topic, I start the question. In this COVID scenario, what should be the temporary dialysis access for the people? what message you want to give to people who want to start dialysis in ICU setting for COVID patients? What should be the ideal vascular access for them?
See, I think when somebody, a COVID patient is on ventilator or in a high flow oxygen, I feel that it will be more comfortable to have a femoral catheter and tide over the problems of possibly a week of acute renal failure with a femoral catheter from the point of view of safety of the healthcare worker. This is my...
I think very rightly said, the message should go that you have to remain as far away from mouth and oral cavity. So possibly a femoral catheter or maybe a subclavian.
Yes.
Today we don't recommend normally that a subclavian catheter should be placed because of the stenosis part, high rate of stenosis. But in today's time, if you want to go avoid supraclavicular region, so you can put a subclavian, and keep in mind that 25% of the patients in ICU, that is the US data, will require prone positioning.
Yeah.
And the femoral catheter may not be handy if you have to put the patient in prone position.
Yes.
Whereas the subclavian catheter may be handy in those situations.
Yeah, beautiful, sir, because you have reinvented a procedure which is now almost gone out of vogue. Because as a postgraduate, way back in 1992, we started our central catheter insertions from subclavian. I think most of our junior nephrologists would not have inserted a subclavian catheters in such large numbers as you and me and Bala have done.
Fully agreed, because that is if you really ask me, in our time, we never put IJ catheter. It was only subclavian. But later on, we learned about it. Now, second, I will try to ask, how much gap, first of all, for the audience, between the tunnel catheter and non-tunnel catheter, what is the difference in infection rate?
So definitely the non-tunnel catheters get infected at a median time of 2 weeks. So this is the, I'll count the patient as very lucky if he hasn't had an infection in the last one month post-catheter. So 2 weeks is the time.
As Dr. Sampath mentioned, the KDIGO recommends that if you have to have a vascular access for over 2 weeks or 2 weeks, prefer tunnel catheter over non-tunnel catheter. We had a recent publication, I think, from Vellore, where the non-tunnel catheter infection rate was this year only, 7.4 per 1,000 days, whereas if I recollect Dr. Sampath's article way back in 2011, the infection rate was less than 1. Our own data, we just sent it for publication day before, experience with 221 catheter, and without using any antibiotic lock or anything, our infection rate is less than 1 per 1,000 days. So that is a gratifying feeling for the catheter. The one important point Dr. Sampath mentioned, that Bombay experience, which I was also not aware, that if there is a biofilm, or if the person is classically having an infection, then one can try and use ethanol in these people. That if you put 70% ethanol in both the venous and arterial hubs and leave it for 6 hours and remove the ethanol after that, possibly there is a gratifying benefit.
Yes.
What are the complication rates? Because one point one has to be very clear. In COVID era, people are scared that if you put tunnel catheter, that God forbid, a person is already on ventilator, person is already having pneumonia. Now, there is some percentage of people who can have complication like pneumothorax or hemothorax, and that can be catastrophic. If in such patients, a person is putting a tunnel catheter and such complication occur, which can be catastrophic. How common are these to be honest, in our 227 catheters which we are publishing, we did not encounter a single pneumothorax. Your experience?
I have also not experienced pneumothorax, touch wood. But these complications, we will have to be mentally be prepared, and also see to it that you take all precautions and do everything under very good guidance.
Yeah,
So,
if you are doing fluoroscopy,
really important. So we have seen some nephrologists arguing that fluoroscopy guidance may not be required. I would urge that for our own protection, I think for our safety, I think fluoroscopy guidance is a must. Without fluoroscopy, we shouldn't venture into.
The point very well conveyed.
Yeah.
And people who are developing pneumothorax, by and large, they are the people who are doing blindly,
Yes.
with overconfidence that, okay, we can put it like that. But in today's time, fluoroscopy guidance is a must.
It's a must.
Any questions you are getting, because I am not getting the questions here.
Right.
Dr. Mayuri?
I have 3 questions. I have selected 3 questions which are pertaining to this topic, which have been frequently asked.
And one point also I want to tell, important point Dr. Sampath mentioned, that once you are just, to avoid the air embolism, possibly you are putting the patient in Trendelenburg position towards the end.
Yes.
Can you just highlight that again?
Yeah. So when you are putting in the peel away sheath, it is ideal that you ask the sisters to slightly tilt the head end of the patient down, and also ask the patient to hold his breath. So these 2 small maneuvers will really make it more safer.
A question about, just a point about the dreaded complication, that is the catheter-related bloodstream infection, which, as you mentioned, is going pretty down now. We surprisingly find that gram-negative infections are becoming more important, though the literature reports that almost 50-60% of the infections are due to gram-positive organisms. What is your experience now?
No, here, see, the problem is, in my unit at least, I have not had many positive blood cultures. So possibly to do with the microbiological growth spectrum, and also as well as culturing techniques, we have not had, and whatever we had are always been gram negative.
Correct.
Gram positives.
That is an interesting point, and that is a point it must be kept in mind, that we always say gram positive. It is the data which is appearing from Spain, one of the data which is they have stretched over 20 years, and initially they were gram positive. Over a period of time, they are becoming gram negative. A data from Vellore, where they find 54% of the infective organisms were gram negative, and find that 77% of the infective organisms are gram negative. I will ask Professor Georgie, who is there. Professor Georgie, any questions you will like to ask? And Dr. Bala also, because as a panelist, any question from Dr. Sampath?
Sampath, very nice presentation with simple cartoons, and Dr. PP Verma has put in the role bowling. I just want to ask you, because I was speaking to one of my students who is working in Memphis now as a critical care. They said that they are doing the chemo extracorporeal thing, and a lot of them are clotting. Clotting is an issue with COVID, and something like a hemophagocytic syndrome. And so they find it extremely difficult to maintain the circulation going. And so did you encounter that in any of your practice with the COVID patient? If so, what should be the treatment? Because I understand that they use a lot of anticoagulants, and despite that, the circuit clots, and they may have to change the dialyzer repeatedly.
Yeah. So this is again, we are reading in the literature and also in the group discussions of people who are been using treatment hemodialysis in COVID positive patients, that clotting is a major issue. Because of the lack of personal experience, I don't think I can give you an answer, sir. But I think the large volumes, the procoagulant state gives it this is a real problem, and that is where I think peritoneal dialysis may score over in these patients. We may have to
Dr.
resort
Georgie,
to
what you're
peritoneal
saying is
dialysis.
very valid, even there. Now, instead of normal, what heparin you are using 50 units or 100 units per kg, possibly they are going up to 150 units because more of heparin is being used. I think the data is coming from there, what should be ideal way, but we don't have personal experience of that. Yeah, Dr. Mayuresh, your questions.
Sampath, can I?
Yeah.
Yeah.
Yes, sir, please.
Sampath, you are talking about catheter exchange. Do you have any preference for the new catheter to be used? About the tips or the type of catheter, which will be easier to use when you exchange.
Ideal will be a symmetric tip, because split tip you will always when you are putting in through this, it is ideal that you have a symmetric tip or a step tip.
Plus, I was wondering if the now somebody has this easy flow catheter where it has a guide wire sort of thing inside already. That will make the catheter stiffer. I think we may prefer that over a regular catheter. Glide path, sorry, it's called glide path catheter.
Dr. Sampath, just a query from you. When do you prefer to change the catheter? If a person has got CRBSI and you are to remove the catheter, you have tried antibiotic for 3 days, there is no benefit occurring, you are removing the catheter. When do you prefer to put the catheter? Like we try to give a gap of 1 week to 10 days and then put the catheter unless there is a dire emergency. What is your policy?
My view is also that we need to have at least 1 week before, because even though we are going to have a different tunneling site and the tunnel, it is better we err on the side of caution and then leave a gap of a week and put them on temporary catheter and then come back.
Yeah, Dr. Mayuresh.
Yeah. So I had 3 questions, but one of the questions is already asked by Dr. Bala, which was also asked by an audience member. The first question is from Dr. Manjunath Doshetty from Karnataka. He asks about pediatric population. How do you select the length of TCC for pediatric population? And the second part of this question is for TCC inserted through IJV, what will be the implication if the tip goes to the upper end of inferior vena cava?
See, as far as the pediatric catheters are concerned, I don't think I have great experience in inserting it in pediatric patients. So, as far as the second question is concerned, when it goes into the inferior vena cava, it is the reason possibly why it has gone into the inferior vena cava is that the exit site has been chosen a bit too high, and so the length of the catheter, most of the catheters has gone in. So this is a technical issue, and we should at this stage, if you are trying to pull out the catheter, it is very likely that the cuff may come out from the exit site. So once you are in at that time, at that period, into the IVC, and once you realize that you have gone in too much, better that you keep it there and then see whether the flow is coming. If the flow is good, leave it at such. If the flow is not good, then you take a chance and try to remove the catheter by a few centimeters and see whether you are in the end of the right atrium.
Yeah, I think
Next one.
you are right, because catheter tip in the IVC, it may not be a bad thing because we have translumbar IVC catheterization in a very bad situation. I think you can leave it at that. If the flow, flow should be okay.
Flow should be good.
Right. So there are 2 questions, though they have already been covered in your presentation, but they have been asked frequently. Maybe there was some streaming issue, they could not hear you, or maybe some other technical issues. 2 questions. Why only choose the right side? This is the first one. And the second one is, can you please repeat how to release the kink? Yeah.
So the right side is always preferable because of the straight course of the right internal jugular vein as it joins the superior vena cava. So what you are seeing in the one plane of drawing of the left internal jugular and left innominate vein joining the superior vena cava, you should understand that in a three-dimensional view, it is not only a straight curvature, the curvature can be antero-posterior also. So you have to understand that. So there are a lot of the curves that the guide wire as well as the catheter and also the peel away sheath have to make. So never choose left internal jugular vein if you can avoid it. So ideal that you go for the right side always. 90% of my catheters are on the right side. Only 5%
maybe more.
of the
Maybe more possible.
Yeah, more than that.
And keep in mind that the life of catheter on the left side is not even half of what the life is on the right side. Just a question, Dr. Sampath.
I already told you that you have to just give a tug, small tug, and at the hub of the catheter, and then the kink most often will go away.
Can I add, Sampath?
Yeah.
Please, Dr. Bala.
Yeah. So the problem with the left side is, as Sampath was telling, because of the multitude of the curves and dimensions, plus when you put in the sheath before the peel away, see the length of the sheath, it may not take a curve to the right into the innominate. Even though the guide wire is taking a nice course, if you blindly push the catheter with the peel away catheter, the trocar and the peel away catheter, you may kink the guide wire and injure the innominate. Yeah. Plus, and the tug Sampath was mentioning is to release. See, there will be a tissue in the curve of the the catheter making the kink. So this tissue has to be released. Then the kink will go off. So by Sampath, by doing his tugging, he is sort of taking away the tissue. But you can also have a artery forceps, and you can nibble and separate the tissues, which is making the kink. So that is the principle behind the tug which he is telling about. If it is not being released, you can take a artery forceps and dissect the tissue which is holding the catheter in a kinked position.
Dr. Sampath, what is the thrombosis or blockage failure rate in your experience?
Thrombosis most often is due to nurse's inadequacy of the heparinization. So when we have these patients come back, we have found that urokinase has helped. So we lock it with 50,000 urokinase, 50,000 units in each limb, and most often we have escaped.
How often you have found endocarditis in these patients?
I don't think I have. Maybe I have missed, but I have not had.
No, but it was bad. Like we had 3 cases, 2 on mitral valve, 1 on the aortic valve, 3 endocarditis, and one of them we ventured to go for surgery. When they went for surgery, when the opening pericardium, they found all the muck lying, they closed it. The tissue was so soft, they felt that it is not possible. And unfortunately, all the 3 patients with endocarditis, despite aggressive antibiotics, we lost them.
Yeah.
I mean, that is because unfortunately, we are not seeing the metastatic complications like you find epidural abscesses or spinal abscesses. These somehow we are missing because many times the complaints are very non-specific.
Yeah.
But whenever you have got a CRBSI, keep in mind the echo must be done and endocarditis must be looked for.
Yeah.
I think any other question? Dr. Georgie, any comment? Dr. Bala? Otherwise, we shift to next topic.
Yeah.
Dr. Sampath, wonderful as usual. Thank you very much for your very lucid and exotic presentation. Thank you.
Thank you.
Professor Georgie, may I request you now to please take over?
Yes. I extend you a warm welcome to the second part of the webinar. And I thank my co-moderator, Professor PP Verma, Lieutenant General Verma, and also Sambat Kumar and Mayuresh. So renal replacement therapy in COVID is not dependent on a transplant. However, they have done deceased donor transplantation in Kerala during the COVID therapy. And I think that kidney and heart were transplanted. And they did not encounter any problem either in the government setup or in the private setup. However, we already talked about hemodialysis. So peritoneal dialysis is one of the options which can be looked at for simple reason that peritoneal dialysis can be, acute PD can be done by connecting to a APD machine so that the nurse involvement is less. And also in patients whom we think that they have a bad myocardial status, you can do acute peritoneal dialysis. The three important aspects of peritoneal dialysis are: one, you need a healthy peritoneum; number two is an safe access to the peritoneal cavity; and third one is sterile fluid in plastic containers. So the complications, how to implant a catheter. Dr. Balasubramaniam is a professor attached to NKR Medical University, and also my great friend who helps me in conducting the MRCP basis examination in Chennai along with Dr. Sambat Kumar. So Dr. Balasubramaniam is also an ISN educator on interventional nephrology, and I have seen him spending his time in Nepal, 2 years ago, trying to teach them about the interventional nephrology, and he has wide experience in implanting the catheter, in taking care of the complications, at the same time removing the catheter and reimplanting the catheter. So over to Dr. Balasubramaniam.
Thank you, sir. So I'll share my screen. Yeah, good evening, friends. My respects to Dr. Georgie, Dr. Verma, Dr. Mayuresh, and my close friend Dr. Sampath, and the audience who have spared time to listen to us in this meeting. Before I start, let me have some COVID realizations. We know that we are having an unprecedented and a very rapid growth of knowledge and science about COVID. So every day new papers are coming about. More or less the number of papers published, they say, might even go beyond the number of new cases being reported. But because of this, truths become myths in no time. So generally, any publication or anything may become obsolete, but nowadays it will become obsolete sooner than before. But at the same time, some of the obsoletes are becoming current, like BCG vaccination, polio vaccination, chloroquine, colchicine, use of zinc, vitamin C, and talks about native immunity, hygiene hypothesis, etc. Some things which are there for a long time are becoming current now. Whether they are good or bad, it is not yet to be finalized, but we see such things happening. And one such thing is happening in PD also. PD is being looked upon as a better option in COVID times, as Professor Jaji was mentioning just now. Sadly, around 1980s, I saw this quotation somewhere. Some should be a prominent person who said or who thought PD was a second-class therapy for second-class patients by second-class doctors. I think which was a very rude of that person. But we have come a long way, and now in COVID times, we see the beauty of PD and how this might be a better choice. And when we try to discuss today, these are the things we'll have to discuss, but like renal replacement therapy in COVID times, whether it is HD or PD, and doing RRT for COVID positive CKD patients and RRT for AKI in COVID patients, and the comparison between PD, HD, CRT, and so on. But let me not go into all this, but concentrate on catheter incision, who should do that, and what are the issues to expect, and how it will differ from a routine insertion in a non-COVID time. This is a familiar picture we see everywhere, talked about from your neighbor to the Prime Minister: masking, social distancing, washing your hands, and to stay at home. I think this is a too familiar thing going on all around us. And also they discourage patients to go to hospitals. They encourage telemedicine, and which has been made legal. So doesn't this ring a bell? See, this is actually something which we have been advocating for PD patients all along for decades. So it is no wonder that PD would become a better option in COVID times. And why should we be thinking of PD? Not only here, all over the world, because there is a sudden surge in inpatient dialysis needs. That is because many patients on maintenance hemodialysis who missed schedule due to non-availability and not able to reach hospitals end up, with pulmonary edema, and they come with emergency problems. Then there are hemodialysis patients who are being admitted with COVID positivities, who are already on dialysis, they become positive. Then we hear about increase in clotted dialysis. This results in prolonged treatment time and end up with inadequate treatment. And all this is due to the prothrombotic effects of COVID. And also, importantly, AKI is now being increasingly identified, like Dr. Verma was telling. To start with, they thought it was rare. Now they see that significant number of IP patients, and especially in ICU, develop AKI, and they require urgent dialysis. And more importantly, shortage of hemodialysis nursing staff because of the COVID rush, due to they becoming infected, they are not being able to reach, and they are reluctant, and so on. So all these things lead to a rush for acute hemodialysis. And what should be an ideal dialysis modality? Something which is minimally affected by clotting. I'm talking about COVID situation, which is readily available and cost effective, and which is able to clear toxins even in a hypercatabolic patient, which can maintain fluid balance with minimal need for external nursing input. And over the months, we have been also seeing that the concentration or the importance is slowly shifting. First, it was all ventilators. More and more ventilators were being made all over the world. Then later, they thought it was not that important. More patients were getting into renal failure. So mostly they had to be used, they had to take up CRRT. And now slowly things are shifting to CAPD, or peritoneal dialysis in the ICU. And the major advantage of PD would be, you can easily train even non-dialysis staff, and initiate them into doing PD in the ICU or in the ward. So that is an important advantage. And there is no problem of anticoagulation. They're either prothrombotic or not. If they are on anticoagulation, putting in other catheters and all these things, intervention may be a problem, but PD is maybe safer. And one of the main advantage of acute PD is that PD catheter may also serve as a long-term access, because quite a number of these acute AKI patients from COVID wards may need or continue to have renal failure, and they may have to continue dialysis even afterwards. So it would be a good idea to put in a CAPD catheter in the acute stage itself. But there will be some concerns using PD. One is the solute transport and the ultrafiltration capacity. These will be limited when compared to hemodialysis or CRRT. And another thing is, in a given patient, in a particular point of time, you would not know how much you would have a solute transport or ultrafiltration until the session is over. Unlike in a hemodialysis or CRRT, where it is all online, you can set the requirement, you can see it, what is happening. So this can't be done in peritoneal dialysis. So that can make the people who handle this patient slightly hesitant to take up PD. And the problem of intra-abdominal pressure may be there in some of these patients, which might preclude use of peritoneal dialysis. And also the problem of the catheter position, because some of them might require proneness for ventilation. But now with more and more patients are being successfully treated without ventilation, I think this prone ventilation might be needed only in a few patients. And even there, we can modify the catheter placement in such a way you can put it laterally or so and make it convenient even in a prone patient. And by using hypertonic solutions and using high volume cycles and keeping a laterally placed catheter, I think we can get over most of these concerns and choose PD. But still, PD has to be avoided when there are problems like breach of peritoneum, when there is active peritonitis, any bowel infection, severe hyperkalemia, when there is severe respiratory failure and pulmonary edema, and and all this situation, you may have to think of an alternative. And coming to PD catheter insertion, this is the list of the usual insertion techniques we have, from percutaneous insertion, mini surgical insertion with internal cuff fixation, to open surgical insertion, single puncture peritoneoscope method, and laparoscopic insertion. But for a situation like today's discussion, I think only these two are relevant: percutaneous insertion with PLV catheter, or a mini surgical insertion, which can be done in bedside, even outside the theater. And all the other three will not be relevant for today's discussion. And why nephrologists? And we know that in a time like COVID, when it was coming and picking up, it was nephrologists who, we continue to give our services to our patients, unlike most of the other, departments and specialists. They simply stopped working. But as nephrologists, we continue to work, giving service to our dialysis patient, whether COVID positive or not, whether we are 60 or 60 plus, we kept continuing. And as such, our association with critical care has been, very long, and our importance is there, is very well known. So we were there. So nephrologists, as nephrologists, we cannot go away. And if there is a need for PD, I think we should be the one to be doing that. Although we know that we have had some sad stories, like somebody, young nephrologist, losing her life, but that cannot keep us from refraining doing good for these patients. And we have great leaders amongst us who with a lot of empathy and are showing us the way that nephrologists, we should be with our patient through the high or the low in their life. And one important point how it differs from a regular catheter placement is that this has to be an urgent start PD, and one has to start within 24 to 48 hours. So it will not be a regular PD initiation where you allow the patient to teach them and allow the catheter to to be placed and fixed, leak free for 2 weeks or a week, then start. That can't be done here. So it has to be an urgent start. And we are also not new to urgent start, particularly in our country, where patients, situation and practical, how they land up with without AV fistulas and how they require urgent start PD. So we are already used to the situation. And in COVID time, I think this will be the only way the PD has to be started. So we may not have the luxury of OTs, because most of the OTs were closed, and in centers where surgeons were helping the nephrologists, again, they wouldn't be volunteering at these times. So it has to be we who have to do that. But yet, with all these limitations, with all these problems, it is very demanding, because the placement has to be optimal, because we'll have to minimize the leaks, we'll have to maximize a successful exchange, and the good placement should allow rapid escalation in dwell times. As we saw in the previous slides, in a COVID situation, especially AKI in COVID, they'll be all hypercatabolic and fluid overloaded. So we'll have to start immediately and start with hypertonic fluid with large volumes. And also the exit site location has to matter, in case the patient would require ventilation and proneness, etc. So, we'll have to plan in such a way that it doesn't come in the way of further treatment of these patients. And the routine percutaneous catheter fixation has become very popular, and I'm sure most of the nephrology colleagues, even the junior ones, are familiar with that. But here we'll have to, ensure to minimize leak. So these are the few tips which I can give you to have an optimal catheter placement without early leak problems. So one is using PLV catheter and percutaneous method by itself is going to help us, because we are puncturing, we are not making a nick. So it is going to be a dilatation, it is simply a dilatation of the tissues and the peritoneum. So it will snugly fit with the catheter, so the leak may be minimal. So it is better to use percutaneous method, even if you open the abdominal wall to reach the peritoneum. And the last part, if it is done with the percutaneous peel away catheter, it is good. And use of a purse string suture around the cuff is a good idea, especially if you have opened it. Even otherwise, and I will be showing you some videos where you can put a pursing suture, a pursing tying around the inner cuff, and it will be a good idea to secure the deep cuff with sutures to the deeper tissue or the peritoneum. This is actually routinely, these are the steps I do in my daily practice, whether COVID or not, which has made the problem of leaking and also the problem of migration of catheters to minimum, because I fixed the inner catheter, and which we see in the videos we'll be seeing just now. And also between midline and paramedian, I think here there is a difference, because midline has very minimal structures coming in between. You reach the linea alba and you place the cuff, but if you go any further, you'll be getting into the peritoneum. But when you go in the paramedian structure, you have the anterior rectal sheath, then the rectal muscle. So you have an opportunity to place or bury the deep cuff into the rectus muscle and fix it there. So that way the cuff will have more opportunity to get fibrosed and get closed immediately without any leaks. So to minimize the leak, as I said, preference of paramedian rather than midline. But although this remains controversial, because I've been using midline all my life and my leak rates are very few. But in a COVID situation where essentially you will have to start immediately, I think you may prefer a paramedian approach. And as KDIGO guidelines, ISPD guidelines, using antibiotics in a critical care situation is must. And also the method and how you approach and how you bring out the catheter, tunneling, etc. And it all would depend on the local expertise and the preference of the operator who is there. So we can't impress or put in something which he is not familiar with. So that should be the driving force behind the selection of the method and the catheter. And this picture shows how routinely if this is the inner cuff, you bring it out and have the outer cuff, and if you want the exit side to be higher, then the curve has to be slightly different. But in a COVID situation where you might think that you may feel that the patient might require prone position ventilation in the future, you can bring out the catheter much laterally. So when I say lateral placement of catheter, it doesn't mean that you'll have to puncture here or put in the inner cuff there. You can have the inner cuff just in the rectal sheath, in the lateral part of the rectal sheath, and the tunneling you can bring it nicely and bring the catheter somewhere here, because it is not this which is going to matter when somebody is prone, but the exit point. So I think it may not be a very difficult affair to modify our technique to suit the COVID patient. And this is a catheter insertion which has a small problem in that you see that the exit site has been brought very low down, and I expect the cuff to be somewhere here, the external cuff. So the distance between the external cuff and the exit site is too long. So for epithelialization and sealing of the exit site will be difficult in this situation. And also they have made sutures around the exit site, because probably the surgeon has inadvertently made a bigger incision in the exit point, seeking for closure. I think this should be avoided. You'll have to carefully plan and make it just enough to accommodate the catheter and not require any suturing. And this is a diametric view of how the catheter should lie. Again, here you see that when you put it in the paramedian position across the lateral rectus, if you keep the cuff above the external rectus sheath, and try to fix it there, you might have a acute turning or a kinking of the catheter. So I think this is not the correct method. So you'll have to plan it differently, which I'll show in the next slide. You see, so you go deeper. You can open the rectus muscle with your fingers or artery forceps, because the muscle fibers can be separated, and you can reach the deeper rectal sheath, and you place or bury the cuff here, and I'll show you how you can fix the cuff there. And you bring the catheter out in an angle like this so that there is no acute kinking there. So make the lie like this and bring the superficial cuff outside and get the exit site. And it is a good idea to have to familiarize with ultrasound and using ultrasound before PD catheterization. This is in a catheter, you're looking at the midline. See, this is the rectal muscle either side, and this is the linea alba. This is for midline insertion, and you see there is a pad of fat here. It is important because in very obese patient, this pad of fat can be very big like this. So you can get into trouble if you try this. Put a PLA catheter blindly. The guide wire can coil in the pad of fat, and very nicely it can go without any resistance, and you can finish the whole procedure without realizing that your catheter is going to lie not in the peritoneum but all in the pre-peritoneal fat. So this you'll realize only when you start putting in fluid. Suddenly you'll see that subumbilically there will be a subcutaneous edema. So you'll have to keep this in mind of this pre-peritoneal fat. In this particular ultrasound, this is minimal, so it is very easy to have a midline approach. And it is nice to do ultrasound and see if the peritoneal layer and the bowel movement is free without any fibrosis or loculations in the peritoneum. So you see nicely this is the muscle layer and this is the peritoneum, and you see the bowel moving freely. And also when you are doing a transrectal anterior abdominal wall percutaneous blind method, you should be aware that the epigastric artery, the inferior epigastric artery, you'll have to locate, if you are careful enough to avoid that, because by doing a blind needle puncture, if you injure this artery, there can be a big hematoma here and that will spoil the whole show. So you can do a Doppler and see where the artery is, then you can try to avoid it. Yeah, so you see the pulsating inferior epigastric artery. And this is after making a incision. See, this is the this is the midline. So in the level of the umbilicus or slightly above it, you can make a transverse incision and dissect. You can separate it easily with the artery forceps. This is a fat and subcutaneous tissue, and reach the anterior rectus sheath. One simple method will be, from there you can put in a needle, like needle puncture and put in the guide wire. And if you are, if you had already pre-planned and avoided the epigastric artery, that is fine. But if you are, getting more experience, you can open the anterior rectal sheath transversely again and see the muscle layer, separate the fibers, and you can see the posterior rectal sheath, glistening sheath like the anterior sheath, and there you can put in the needle again. Instead of trying to open it like a surgeon and making a big hole and trying to put a purse string here, you can put in the needle and proceed like a percutaneous incision, like what you do in the routine method. So you see the glistening the rectal sheath, and then put in the needle, and the needle should be caudally placed, directed, because your catheter has to lie like this and get the curve like that. So it is a good idea to slightly give a tilt when you puncture the sheath itself. And using a Veris needle would be a better idea, because it is a contraption where the tip after piercing the tissue, it goes in, draws in, and only a blunt end is there, so you will not injure the bowel. So if you have access to this, it is fine. And we can also use the ultrasound as you puncture. Live you can see the needle and when it is entering the peritoneum. So these are all possible when you are getting used to ultrasound, you start using in your daily practice. And if you want to make it more sure, if you inject a dye, you see that the dye will not go and settle in one place. I was telling you about the midline entry and the problem of the preperitoneal fat layer. And if that is so, your dye will collect like this. It will pool around a place. But if you are inside the peritoneum, it will go in between the bowels and take a pattern like this. Then you are sure that you are inside the peritoneum. And for beginners, we always advocate putting in fluid and separating the bowel. But once you start doing regularly, you may do away with that method. And the position of the guide wire, if you confirm with the fluoroscopy, it is nice. And you see it is taking a gentle curve inside the pelvis, deep inside. And there is, whether it has to be towards the left or right, there is, some people prefer left, some people prefer right, because if it is left, you have the, the cold, and the movement of the bowel is, it is towards caudally, so the catheter will never be pulled back. I don't know whether it is really practically happening like that, but if you put it on this side, and the peristalsis of the bowel will be upward, so it can theoretically drag the catheter up. So it will be a good idea to have the guide wire and the placement of the catheter like this. And one step is to do a purse string around the cuff, I said. The other thing is to fix the cuff. Now, if you try to put in a suture after putting in the catheter, then with a small incision you will have difficulty in taking a bite. So what here I have showed is, so once a guide wire is in, that is the time you make a bite on either side with the vicryl and keep the vicryl on either side. So after you place the catheter, you don't have to cumbersome of trying to take a bite with the catheter and the cuff inside. So I do it pre-handly before putting in the catheter. So this is actually midline subumbilical. You see the guide wire, and on either side of the catheter I take a bite with vicryl. This has two purposes. One thing is with the vicryl. Vicryl is a very strong suture material. I can pull up on either side the abdominal wall with these two sutures, so that when you put in the peel away sheath, you are safely pulling away the anterior abdominal wall away from the bowel. That will be one purpose. And the next is to use the same suture material to make a purse string, and also if necessary take a bite in the cuff and fix it to the, I'm trying to pull up the anterior abdominal wall with the vicryl suture when you put in the peel away sheath. This may not look very important, but small things, if you practice every time, you will escape from rare complications. So this is the regular sheath being put in. And you will have to pull away the trocar even before pushing in the sheath to the hilt. And this is the peeling away. You hold the cuff, and again see that the cuff is not injured very much, because when you are trying to suture the cuff to the anterior, the peritoneum or the posterior rectal sheath, this cuff has to be sort of intact. If you make it wet and make it very thin, then we may have difficulty in suturing. So now you see the cuff in position on the anterior rectus sheath, or if it is in the midline on the linea. Now these sutures were already made. This vicryl were already made and lying that side. Now I am taking a bite in the cuff. One has to be careful not to injure the catheter when you are taking the bite on the cuff, but it is not very difficult. You don't direct the needle into the catheter, but you go from the side. So if you go from the side, what happens is, you will avoid the catheter injury. So this is again on the other side. So I am fixing the cuff on either side with the initially placed vicryl sutures. And once I have fixed the catheter, you see that I cannot pull out the cuff. It is very, very, very securely fixed to the tissues. So, and the leak will be literally nil. And another thing I do is, I don't simply bury the curvature, if it is a pre-curved or not. I don't leave the curve and bury it inside and take out the exit point here. So that way I have a feeling that, during usage of this catheter, if you have a drag on the catheter, you can straighten the catheter and the external cuff may get extruded. So what I do is, if you see this video, there is one thing missing. I will show you. Yeah, you see, I have taken out, I have made a small incision here, and I have brought out the catheter carefully, upwardly. Then again, make a small incision here and bring it down. So making a nice curve. So this, even a straight catheter can be used by giving a curve manually like this. And this step, I hope this video is able to show you, but it is not difficult. So that way, both the cuffs get buried very nicely, and the chances of the cuff curve getting straightened up is very minimal. So you have 3 points, the inside entry point, and for the tunneling sake, another incision upwards, and again the exit point and over. So this is the method I've been using always, and I think for an immediate start, this really makes sense, because the chances of leak and the immediate usage becomes very easy. And actually, as Sampath was telling, we do not have first-hand experience with doing AKI management in our units here. So, we'll have to only extrapolate what we are doing and imagine this could help. And also taking cue from the reports from other countries. One important thing I noted was, experience with percutaneous placement is not as widespread in Western countries as in our country. So you see, they mentioned that it is a technique that can be performed at bedside or in the radiology suite by surgeons, interventional radiologists or interventional nephrologists who learned these techniques for the first time during the COVID-19 pandemic. So you see, that was the state of affair in those countries. There was nobody to do it, and they impromptu, they had to learn and do it then. But I think we are, that way we are already prepared, and most of this were performed by people with limited experience in Western centers. So it appears that India and we nephrologists are better prepared in many ways. Firstly, early lockdown, we sort of postponed the peak. We have not avoided, or we have not escaped. Postponing the peak really mattered, because listening to some of the webinar speakers from US and UK in the early April, how they talk about non-availability of masks, and even rich countries like them, because they were not prepared, because the cases flooded in a very short time. Although we are a poorer country, now we have had time, and now I'm sure there is no shortage of masks and PPE kits, and we have these 3 months have made a lot of things better, and we seem to be better off. And nephrologists as such, we have been always frontline health workers for critically ill patients. And PD is well entrenched into our system. We have been using PD for AKI for shorter duration, like diarrhea-induced AKI and things like that, very successfully using stiff catheters. And for prolonged AKIs, like in HUS and situations, we were using this permanent catheters, CAPD catheters. And in critical care, there have been experience of our people comparing CRRT and CAPD in critical care. And also, very peculiarly in our country, there are many institutions, especially government institutions, where PD is started as an initial management to buy time in CKD and end-stage renal failure. That is how we used to do in Madras Medical College in our days, and that is the practice I see in most of the government hospitals in Tamil Nadu. So we are all well used to peritoneal dialysis, and we have one of the largest interventional nephrology community. So I think we are, as a country and as nephrologists, are better equipped to face COVID and problems. I think with that I'll finish, and there will be points to share by other speakers and participants, and let us continue. Thank you.
Thank you, Dr. Balasubramaniam, for that lucid and graphic presentation of implanting the catheter, and also showing on ultrasound, how easy it is to see that the catheter enters the peritoneal cavity. And you have also said that when you implant the catheter through the paramedian side, through the rectus sheath, one has to be very careful about avoiding the inferior epigastric artery to prevent bleed. And so these are some of the things which you highlighted. I just wanted to add two more things. Any patient who is going on peritoneal dialysis, please make sure that their rectum is empty. You do a PR or give them a soap and water enema prior to implanting the catheter. And also make sure that the bladder, put an indwelling urinary catheter so that the bladder is not full while you do percutaneous implantation, to prevent a puncture of the bladder. So these are the things I just wanted to highlight. And Dr. Balasubramaniam has very clearly shown how it is a easy procedure to implant a catheter. And I would also say that, one of the things I would just add on to is that when you use a straight catheter, I have seen it time and time again, when you want to make it as a swan neck type, the memory of the catheter will, in the intraperitoneal part, will move into the straight position. So it is always advisable to put a swan neck catheter. And also Dr. Balasubramanian highlighted about using two cuff catheters. You have an inner cuff which will go to either the linea alba or to the rectus sheath, and the external cuff is the subcutaneous tissue. And the distance between the external cuff and the exit should be at least about 2 to 3 centimeters from the exit. And that practice of putting a stitch at the exit site is not at all recommended, because you have some collection of fluid there, blood and extracellular fluid, which has to be easily drained out through the exit site. And so these are some of the points I just want to highlight. And Dr. Bala can take questions if there are more questions which are coming in. Mayuresh? Yeah.
Just a question, if I can ask Dr. Georgie. Your comments on stiff catheter.
Yes.
In our days, we used to start acute PD with stiff catheters. I don't know whether the stiff catheters are now being available or not. Instead of starting with CAPD, it requires a technique. Why don't you start with a stiff catheter? Agreed, you cannot have prone position with that. But starting dialysis with that, your comments. Yes,
definitely stiff catheter is cheap and it can be implanted easily. But the only thing is that, visceral injury, and if you are keeping the stiff catheter for more than 48 hours, the chance of non-function is very high. And also at the same time, leaks are more common with stiff catheters. We still use it.
Yeah.
Also, sir, in emergency situations, in very sick patients, I hear that there are cavity catheters. Arrow makes one cavity catheter not meant for peritoneal dialysis, but it has a terminal curve and it has side holes. It can be just put in with a trocar easily, and in very, very emergency situation where situation warrants, that can be used. Better than a stiff catheter.
Okay.
Any more
Any
questions, sir,
questions?
from the panelists, or we move to the questions from the audience? Sir, you are mute, sir. Sampath Kumar, sir, you are mute.
Sampath, you are not. You have to
Unmute, sir. You will have to unmute.
Sampath, you have to unmute.
Yeah.
It was a beautiful presentation as usual. I just wanted to ask your opinion about this double cuffed catheter, the soft catheter that we use for CAPD. There are now in the Western countries, when they are having COVID positive patients, what they do is they don't have this tunneling procedure. They just insert the catheter with a peel away sheet, and then they come out with the external cuff outside, and then they start the peritoneal dialysis for short period, say 1 week or 10 days. What is your view on that? Because this can be useful also as a temporary catheter.
Bala Subramanian.
See, you notice that most of the persons who started these PDs in those countries were naive, and they were doing it for the first time in that situation. I think it takes additional minute or more, and the tunneling is not going to make the procedure more morbid any more than that. So I don't think there is why you should stop short of putting the tunnel.
Yeah, let me just add on to that. The advantage of a distal cuff is that probably it will also act as an anchor in preventing the catheter, coming out, because you keep on proning the patient and then supining the patient. So that will be a better thing for anchoring the catheter to have a double cuff catheter.
Yeah.
Dr. Bala, just a small point. People are aware that in a isolated or single or some occasional case, the virus has been isolated from peritoneal fluid. And your comment on the disposal of effluent.
See, like what we were doing with hepatitis C and HIV, how we were advised to, use hypochlorite to dispose the fluids. I think the same procedure has been advocated for in COVID situation also.
May I just add on to that?
Yes.
You add 10 grams of bleach to 1 liter of fluid, and then have it in the sink. You pour it into the sink, and then you have the dialysis effluent added to that, and then flush it.
Okay.
Most of this COVID, whatever it demands, we were already doing for PD all these years, sir. That is the thing which I see.
Sir, we will take 3 questions from the audience. Taking a cue from Dr. PP Verma sir's question, what is the can we continue CAPD in patients who are on prone ventilation? Sir had mentioned about the rigid catheters cannot be used.
Yeah. So if you had pre-planned and had put in made the exit site laterally coming out, I think one may be able to continue prone ventilation. Plus, Dr. Jaji was suggesting during one of the previous webinars how they'll have to prop up, putting a pillow between the knee and the upper chest. And sir, you are,
Yes,
so we'll have to innovate, do something. Because,
yes. So that, you won't have too much pressure on the abdomen. Pillows, 2 pillows, 1 pillow and 1 above.
The second question is, what is the ideal position of the exit site of CAPD catheter?
So that depends on the waistline and the, in a regular situation, the waistline and the dress which they usually wear, whether it has to be above or below it. So you plan it. But you see that the external cuff is not beyond, maximum 3 centimeters. And it is not too close to the exit site because it might get pulled out. And making it longer also, I told you the epithelialization and making it a sterile fit, cannot happen.
So
the exit site location.
Just to add on, Bala, the exit should not be in a place with scar, and the exit should be, if the patient is to go on CAPD, the exit should be visible to the patient, to take care of the exit, when they go on, and there should not be any infection at the skin side. where you are planning to exit.
Exactly. So somebody with a very huge tummy, if it is in the lower part, subumbilical, they cannot inspect themselves. So it will be a better idea to have it above.
Sometimes, Dr. Bala, what happens is that in an old firm patient, there is no anchorage to the external cuff. And you find the catheter is just dangling and the cuff has not got anchored. What do you do with these patients?
Yeah, I have had situations where the skin above the external cuff started necrosing because of the wall is so thin. It happens. So I don't know. I mean,
should we remove the catheter because the catheter is dangling? So the inner cuff is fixed, but the outer cuff is just gone. There is no anchorage.
Can I just answer that?
Yes.
We have a number of case reports published in the Journal of Peritoneal Dialysis, Indian. When you lose your fat or when you become malnourished, the external cuff extrudes out. So what do you do with that? So if the external cuff can get infected in such situations, and if you have a cuff extrusion and infection, what you do is you deroof the cuff and then you remove the cuff material from that and have the catheter without a distal cuff. The other thing is what you can do is you can re-root. You don't have to remove the catheter. You can re-root and have the external part of the cuff or external cuff in there through another exercise.
Okay.
I have had situation where, once the external cuff gets extruded and gets infected, rerouting or things like that might be a problem. So I have cut off the external cuff and made the cuff come out. So sort of a single cuff catheter, and put the connector proximally, and I have continued PD in some cases like that. You cut and take away the external cuff.
Yeah.
And you bring it out higher up and connect it to the PD connector. So it may not take you long, but it will give you a lot of time because there is no infection in the internal cuff and the PD is doing well. Only the external cuff was the problem. You can do this.
Anything else, Dr. Mayurish?
No, that should be it. Yeah. I think if there are no further questions, Bala and Sabal Kumar, you need really, a round of applause for your right.
Thank you, sir.
And my friend, Lieutenant General PP Verma, deserves a lot of appreciation for taking his time out from a private practice and coming there. I am speaking from my bedroom home. So you have seen a part of my bedroom and my wife coming in to give me a glass of water. So
it has been a pleasure.
I think that it was a real pleasure and it was a real treat. And I thank Sendu, Dr. Mayur and Ajit Nair for this wonderful occasion to do this webinar.
Thank you.
Also,
Thank
thanks
you,
to St. Jude, Dr. Mayur,
then
and
I
Dr.
think
Ajit. Pleasure with Dr. Sampar, Dr. Bala, and of course, iconic Georgie. Thank you very much.
Thank you.
Thank you, sir. Thank you. And stay safe.